Two massive stories in kidney cancer in 2015. The first story is based around a PD-1 inhibitor called Nivolumab. It's an immune checkpoint inhibitor, it's an immune type therapy. It's been tested in individuals who failed first-line targeted therapy, so it's a second-line trial. It's compared itself to everolimus, which is a standard of care, and it's shown a big difference in overall survival, with approximately a 5-month survival benefit and about a 30% reduction in death. And these two, when you put them together, it's the first time we've had a big survival advantage in kidney cancer, actually in any of the trials, because some of the trials were complicated than before. I think VEGF targeted therapy makes a big difference, but this really is a very clear patient-focused benefit, and it's a very important drug. It's well tolerated. Two big problems: we don't know in whom it works. So at the moment, like all the other drugs, we're treating everyone. And number two is it's actually a very well tolerated drug, but as in our community, we haven't really got the hang of treating patients with immune checkpoint inhibitors rather than VEGF targeted therapy yet. So some work still to be done on refining it, but I think for me, this is what I would want to give my patients when they've failed VEGF targeted therapy, and I think it's the go-to treatment for patients who have failed VEGF targeted therapy. So that's the first massive story. And then a second story, which is also huge, is Cabozantinib. Cabozantinib is a VEGF inhibitor and a MET inhibitor. It's been tested in exactly the same population. So individuals who failed sunitinib and pazopanib, what do we do next? And Cabozantinib is also shown to be a whole lot better than everolimus, both in terms of progression-free survival, and that bit is significant at the moment. And that again is a 42% reduction in the chance of your cancer growing, with a big trend toward a survival signal. It's not mature yet, it will be next summer. And so these two trials, for me, what I'd want to be doing now is, instead of giving sunitinib or pazopanib first, and then axitinib, and then everolimus, that's a standard that we talked about, and mixing everolimus and axitinib. I think both axitinib and everolimus go second tier, and I would say that Nivolumab and Cabozantinib are two first-tier drugs. So, in half an hour's time, we're going to completely change the way we treat kidney cancer for the foreseeable future. The patient global community is energized, or has been energized, by VEGF targeted therapy back in 2007. It's going to be energized again by these drugs, and patients need to know, I think, that there is a treatment out there, or two treatments out there, immune therapy and Cabozantinib, but particularly the immune therapy, which is a different novel mechanism of action with fantastic results and a small chance. And what we're working towards is long-term remission. And these drugs are now being taken into the first-line setting. So we're now testing them against sunitinib. And I'd be saying to patients, if it was me, I'd be wanting to get onto one of those first-line trials, trying to get early access to immune therapy with the hope, and that's the goal, is long-term durable remission.